Hello, you're in the right place. So I'm Alison Campbell and I'm here tonight. I'm waiting for my colleague. I'll just switch him off there. Mark Wilcox is on his way. It's nice to see you all arriving. And tonight we're going to be talking about starting fertility treatment in 2021. It's part 2 because our wonderful colleagues, Dr Sefton and Dr Barry, were here, I think, about a week ago, absolutely inundated with fantastic questions. So we're going to pick up some of those, do a bit of a recap on what they spoke about, and take more questions as we go along. So, just waiting for my colleague, Mark Wilcox. I'm Alison Campbell. I'm CARE Fertility's Group Director of Embryology. And so I oversee the laboratories across the group. And my colleague Mark Wilcox is my clinical counterpart. So he will be here very shortly to introduce himself. And lots of waving, this is nice. View request. I'm going to go live. Just take a second to hook him up. So lots of questions have been submitted in advance. We've got questions. Hi, Mark.
Thank you for accepting me.
Oh, you're very welcome. Nice to see you. How are you?
I'm Mark Wilcox. So I'm CARE's Group Medical Director. So that's across the CARE Group. For the Zita West listeners or patients, just to explain that we are representing you as well. Zita West is linked with CARE London, and so part of the group. So this evening we are really going to have a number of, we're going to cover a number of different topics. It's around about half an hour or so. We can answer your questions if you post them as we go along, but we've also got a load of pre-prepared questions that were posted on a similar event last week based from Chester, Vicky Sefton and Amy Barry. So today we're going to cover briefly about how we're keeping patients and staff safe in the current environment, vaccines, preparing for treatment, pre-treatment tests, embryo transfer, any additional treatments, and general fertility questions. So that's our broad topics that we're going to cover, and then any others that you bring up that we feel appropriate. There are a couple of upcoming events, so we probably won't be going into great detail about donor eggs, sperm and embryos, because we're going to be covering that at a later date, and likewise about male infertility, although we can cover it partly.
Yeah, I think that's better, isn't it, if we focus on different areas each time, because there were lots of questions about donation, I think, sent into the last session. So we're going to do a session in a week or two focused solely on that, and also male infertility is another hot topic. Okay, so some of the key points, if we just run over general information, which I think is always useful, is to say that all the main care clinics are open. We're offering very safe treatment for new and current patients. The government guidelines as they stand say that patients are allowed to leave home for medical appointments, fertility treatments, and investigations are, of course, medical appointments. If we just talk a little bit about how the measures we've put in place in our clinics to reassure you that they are considered to be COVID safe. We've got a group of experts working together to make sure that we review the practice regularly. We're doing lots of virtual appointments where possible in terms of consultations and teaching sessions for injections. So minimising the footfall in the clinics and making sure they're very clean and safe places.
Yeah, I mean, I think it's fair to say that we're sort of getting the hang of it now, as a lot of businesses have. In say May, June, July of last year, when we were reopening, we were sort of finding our way a little bit. But we've now got it organised, and it's been very reassuring that we haven't had any evidence of transmission between staff to patients or vice versa. And therefore we feel that the measures that we have in place are appropriate. You may feel that you don't see us walking around in great big hoods and FFP3 masks and all that sort of thing, because it's not appropriate in our circumstances. So what we are doing is safe. And I think the key messages are as they always are, which is basically don't do anything unless you have to. So don't come to the clinic unless you have to, but it's fine when you do. If you wash your hands, wear PPE, and do as you're told, really, and then we can keep it safe.
Yeah, brilliant. And so then if you're a new patient and you want to book an appointment, then the way to do this, because this session is really about starting out with treatment, then to call our new patient inquiry team. And we've got a number, it's on the website, but I can say it now. It's 0800 564 2270. If you're an existing patient who's currently in treatment, then you need to contact the local care clinic where you're having your treatment. Okay, so should we move on to the some of the points, just the highlights really, and the key points from the session with Dr. Sefton and Dr. Barry, because they had so many questions, mostly seemingly focused on COVID-19 and a lot about NHS referrals and treatments. That is available to watch back on Facebook, Instagram, YouTube, and on the website. So anywhere you like, we're quite good with our social media, I think. So the key points, do you want to go over those, Mark, with the
yes,
about the COVID safety measures, but the partners accompanying for appointments, it's a very important question.
It is. So again, if we're minimising the number of visits that you make to the clinic, we're also minimising the number of staff that you will see in the clinic. That doesn't mean to say quality or safety is compromised. It's just that if you can work from home, we're encouraging that. So Ali and I are socially distanced by about 200 miles at the moment. It's a little extreme, but nevertheless, if you're reducing the number of people coming by doing video consultations, and we can even do bloods at home. You can do finger prick blood testing for some of the hormones that we need, and dropping off semen analyses and things. We've made arrangements for that. So that's reducing the number of times people are coming to the clinic, but also the number of people coming. So we are discouraging partners to come if they don't need to be there. Now we realise that this is a key part of your journey, and it's very exciting and it's very important. So we appreciate that maybe at the time of an embryo transfer or early pregnancy scan, that's a particularly important time, and providing social distancing measures and allow it within the geography of the clinics. It's very difficult to comment on all 12 clinics at once because there are very different facilities in each. So if it's allowable, we may allow it, but it's may rather than will. So just bear that in mind and try to be understanding. So in trying to keep you safe and us safe, there are these measures in place.
Yeah,
and for me,
it makes me sad. It's so sad when partners aren't able to go into the embryo transfer room. But hopefully this will be over this soon. And it's not the case. It does depend on the size of the room that we've got and the risk assessments that we've done. But we do our very best to accommodate wherever we can. Oh, yeah. We just had a question. Should we be agile, Mark? And when the question comes in, it's a quick answer. We had one just there from Tia Maria asking whether we're still accepting egg donors at this stage.
Yes, we are, definitely. And we're accepting all treatments, really. So that goes for NHS, for donors, for fresh treatments, for frozen treatments. I think the only thing that we perhaps are erring on the side of caution a little bit is maybe we might suggest a freeze-all, for example, in a fresh cycle if we feel that the ovaries have responded a little briskly. So rather than risking, in inverted commas, anything to do with OHSS or complications of pregnancy, we may decide to freeze all the embryos and come back later for a frozen transfer. That doesn't compromise your chances. It will disappoint you because it delays things by a month or so, but that, in the grand scheme of things, that's not the most important thing, and that's what we are focusing on, which is to keep things safe. But for egg donors, yes, we are. Yeah, absolutely.
Yeah. And another one just popped up about a backlog. Do we have a backlog for treatment?
No. So I think that we got into a bit of trouble with this last time, I think, when I commented on this, because there were patients said, well, there are waiting lists. We can't get our NHS treatment. But in effect, it wasn't our waiting list. It was the CCGs who control the money that comes through to follow and pay for the treatment. So we have now worked through the backlog in inverted commas. There was a little bit of a waiting list last year, but we're through that now, and we're down to business as usual, albeit with those caveats that we've already spoken about. So no, there's no, for NHS or private, there's no need to wait.
No, it's good news. Should we move on to the vaccine? It's a hot topic.
This is all me, isn't it? Yeah, so it is the hot topic, isn't it? I mean, that's what, and it's good news. Yeah, it's good news that there are 2, or is it 3 now, vaccines approved for use in this country, but 2 are being rolled out. They are different, so they are not the same, but the advice is pretty much the same, whichever vaccine. Now, currently, no one is suggesting that patients who wish to become pregnant should defer their naturally conceived pregnancy or treatment. So that's the first thing to say. If you are offered a vaccine, then presumably you are in a high risk category. You're in one of the top 4 categories because they're the only people that are being offered vaccines currently. Therefore, I would suggest that it would be sensible to take it because you've been identified as at risk. It's a personal choice. Personally, I would jump at it. I think it's a good thing. It is, all the science says it's safe. People have different views on it, but the science says it's safe. So we would say, if you're offered the vaccine, take it. Then, does that delay pregnancy or treatment? And I think the answer to that is clearly no, it doesn't. Initially, there was a thought that maybe it should be deferred by a little bit, but the Royal College of Obs and Gynae and the Joint Vaccine Committee, or whatever, have determined that it is safe to continue with treatment and you don't need to defer anything. There is no scientific or logical reason why the vaccine should impair your chance of conceiving or cause problems in pregnancy. And therefore, getting vaccinated in pregnancy is a different issue. I wouldn't want to address that. I'd leave that to the obstetricians. But again, there's no evidence that it should cause harm. Yeah,
we had a specific question, someone on Clomid, can they have the vaccine? So presumably from your answer, yeah.
As far as I'm concerned, taking a few tablets at the beginning of the cycle and trying to is same as trying to conceive. So yeah, take it.
Yeah, it's I'm listening to you. I'm seeing these questions coming up. I've got a list of historical questions, scribbling some notes, and then you might have seen me smiling. We had a lovely compliment there from somebody called Mother to Daughters, saying that what wonderful work we're doing at CARE. So that's really nice to see. We're doing our best. It's strange times, but we're doing a good job. We're doing the best we can. NHS funding, lots of questions that Amy and Vicky addressed last time. It's a difficult one, isn't it, Mark? Because it depends very much on where you live. It's just exactly how the landscape is in terms of treatment. So it's a hard one. But we do have a nice video that Professor Charles Kingsland did for the Fertility Awareness Week. It was back in November, all about NHS funding. So it might be worth people going to have a look at that, as well as the video, the Facebook, the Instagram live from Vicky.
And I think it's probably fair to say about the NHS, if they have a concern about the NHS, it's not when they come through to us and refer through to us. It is perhaps the availability of your local hospitals to investigate, do the basic investigations, make the diagnosis and then make the referral may be more limited. I mean, we've all seen the pictures on the telly. They are very busy, and the infertility clinics won't be taking a priority at the moment. So you may experience a delay in referral through from your GP to the NHS. We don't have a delay, obviously. We can, we are seeing patients and doing a video consultation as well as Ali mentioned is very appropriate, and getting the basic test done. Doesn't commit you to complicated treatment. It just gets the diagnosis out of the way, maybe give you some reassurance to enable you to carry on trying.
Yeah, great. With the next section, we wanted to come on to some of the new questions. So I think we've done the best to recap on what's gone on in part 1 of the this Instagram short series. But so we move on to preparing for treatment. It's very important, obviously, and if we could talk a bit about the supplements that men and women should take before they start IVF. And again, it's very individual, so we're going to have to talk quite generally. But our website is always a good place to start in terms of the recommended supplements, and also the Zita West website. they're really amazing and specialise in nutrition and health and supplementation. They're very experienced. We've got a lot of information on that website as well.
Yeah, it makes absolute sense to be as healthy as possible before you conceive. That's just a basic. And I wouldn't want to say more than really the Zita West Clinic is experts in this field. So have a look at their website and they will take you through that. I think there are some basics that you definitely need to do, and there are some others that you can think about. So the definites are not smoking, not drinking too much, taking folic acid if you're a woman. These sort of things are very important.
Yeah, well, folic acid is a good example, isn't it? But other supplements, we wouldn't recommend taking them unless you've had a consultation and they're recommended personally for you, because they may not be helpful in some
specific reasons to take these supplements, and one of which would be something that we've introduced recently, which is based on a semen analysis. And Ali would probably be best placed to mention that, but it definitely relates to a semen analysis. And it's interesting that I saw on the BBC website earlier this week that Rod Gilbert was talking about male fertility, and he's a comedian, but he's obviously had investigations and things. He's very open about it, but talking about the lack of andrology opinion, and we do concentrate quite a lot on women, and the men are equally important. But Ali, if you want to say something about our USS test?
Well, I think you're right, and certainly over the last couple of decades, male side of things has been a little bit neglected in terms of research and treatment offerings. At CARE Fertility, we have a scientific andrology focus group. So this is a team of scientists, and we also have the same in the medical side, a team of medics focused on andrology matters. So we're always reviewing the literature, treatment options, and trying to make sure that we have we focus just as much on the man as the woman, because in many cases, and certainly historically, everybody was focused on the woman, and of course it takes both an egg and a sperm to make a wonderful viable embryo. So this test that you just referred to, Mark, we call it the SOS test, sperm oxidative stress test. I won't go into great detail, but it's a new test. We think it's really helpful. Really, if any of the semen parameters are below normal limits, then we can do this very quick test, which gives us a lot of information about the level of oxidative stress on the sperm, and this can affect the sperm motility, its morphology, and go on to affect embryo quality. So it's a simple test, and if we get a result that concerns us, then we can treat it quite simply with antioxidants. So it's certainly worth considering if there are no abnormal or suboptimal semen parameters.
Yeah, absolutely. And thinking about preparing for treatment, weight comes up on a frequent basis. The NHS tends to have a limit of a BMI of 30. You have to be 30 or below to access treatment. We would also have a limit on our private patients of 35. So we recognise that between 30 and 35, the chance of conceiving may be slightly reduced, but we're happy, if the patients are happy to take that slight reduction or are unable to lose weight, then we would go with that. But above 35, it then becomes a bit not necessarily dangerous, but complications arise more frequently in pregnancy with a BMI above 35, and that's well recognised. So that would be our sort of upper cutoff for that.
What about BMI for men?
Yes, there's no limit. There's no official limit on that. But again, it's general health, isn't it? If you are very overweight as a man, the chances are your sperm parameters will be reduced, and you need to get healthy. And of course, if you're that overweight, you want to be around for your children that you're hoping to have. So that would be a sort of very trite comment, but it's important for both couple to be healthy.
Just two people just popped up asking questions about caffeine. That's an interesting question. Is caffeine safe to take during or drink in your coffee or your Coke during IVF treatment? I know when people are in early pregnancy, they often don't fancy it, so probably they cut down naturally. But what about during IVF treatment? Do you know anything about that? Mark?
Yeah, I mean, I think it's everything in moderation, I would say. Yes, you could cut everything out. You know, by the time you've removed everything that could possibly cause an issue, you'd probably be quite miserable and not eating and drinking very much. So I think I have a more practical approach of saying that don't overdo it. So don't beat yourself up over the odd cup of coffee, that sort of thing, but really don't be drinking lots. That doesn't make any common sense to me.
Yeah. What about when a lot of patients have had fertility investigations in different places, different clinics, or the GP or the NHS? So if they then come to CARE, we don't need to repeat them as long as they're not really out of date. Generally speaking, we can accept results as long as they're recent and build on those. We don't need to go through and repeat everything all over again.
No, I put a little proviso on that to say, provided that the tests have been performed in an accredited laboratory. So there are national and international standards, and if the laboratory conforms to those standards, then absolutely not. You don't need to repeat them. Yeah, that's it. So we've got white is one coffee a day. Is that okay? Yes, it is. I think that's fine. That just popped up there. Yeah.
Yeah. And actually, decaf coffee isn't too bad, is it? When you can get some nice decaf coffees. I know I was working in Italy when I was pregnant many moons ago, and they had this funny coffee called orzo, caffè d'orzo, and it was made out of a grain, I think. It didn't taste anything like coffee, but they were trying to force feed me. But you know, when you're in Italy, it's nice to have a proper cup of coffee.
So I'd ask you, have you ever drunk it since?
No. No. So what about time frames? It says here, what does the time frame look from consultation to embryo transfer? That's a good question, isn't it? It's nice to sort of set your expectations when you're about to embark on treatment.
Yeah, there's no great panic. That's the first thing to say. A month or two here or there biologically makes no difference, and psychologically it can make all the difference. So you need to be well prepared. And you need to understand what's going to happen, how it's going to happen, have all your questions answered and so on. And there's numerous ways of finding out that information nowadays. So an average time frame was a consultation. At the consultation, it may be that the doctor's able to make a diagnosis there and then and agree a form of treatment with you. And explain what you're going to expect, and it may be that you have no more tests to be done, but all of those things may just hold things up a little bit. Thereafter, it means moving in then to a deeper understanding of what's going to happen. Lots of consent forms, lots of forms to fill out. There's probably going to be a few more tests to be done in terms of virology testing, for example, such as hepatitis B, C, HIV, that sort of thing. And then planning the cycle. So it's looking at where you are in your cycle. And then what sort of protocol we're going to use, which is best for you. So it may be that we need to manipulate the periods a little bit in order to delay or to bring them ahead, and so on. So it's a difficult one to answer that, but it's not going to be less than 2 months, I would say. In other words, that's a bare minimum. And it would usually be maybe a month or so after that. But you know, we can be flexible. But I think it is sensible to be, as I say, be well prepared and psychologically prepared for it as well. Most important. Yeah,
good. There are a couple of questions just popping up about fresh versus frozen embryo transfer, and the number of embryos we transfer at a time, and whether frozen embryo transfers have a better chance of working than fresh. So if we speak a few minutes about that, we've got a few minutes left. Well, they're very similar actually, aren't they, Mark? The results are equivalent now between fresh and frozen embryo transfer, and we do a very large proportion of frozen transfers now compared to if we look back 5 or 10 years ago. Generally with almost all occasions we prefer to transfer a single embryo, just one at a time. It makes sense. The success rates are very, very similar whether we transfer 1 or 2, but the twin rate is much higher and there are risks associated with twins.
Yeah, you might think that the twin sounds like a good idea. Get it all over and done with in one go. It's not. I've been on the receiving end, as it were, as an obstetrician when I was working in the NHS as an obstetrician, seeing various disasters purely because the pregnancy was a twin pregnancy. Now, most twin pregnancies are absolutely fine. I accept that, but more have problems. And that's why we are very much more focused now to the optimal aim is a singleton pregnancy. So how do we achieve that? Well, if you're putting two embryos back, you're increasing the risk that they both stick and both create twins. So our twin pregnancy rate now is, Ali, you'll know it off the top of your head, and I'm going to guess that I think it's probably just less than 5% across the group. Oh, 4. All right, there you go. All right, okay. So that is very different to the 30% or whatever it was in some clinics not that long ago. So we're much better at it, and we're not compromising your chances. So in other words, the first embryo that goes back is the most important one because that's been chosen as the best one. Number 2, all number 2 can do is threaten the chance of number 1 if it's a twin pregnancy. So it isn't logical to put 2 back on the vast majority of occasions. It's much more logical to put 1 back.
Yeah.
I would agree.
That's good. We'll just move on briefly to additional treatments, another hot topic. One of the questions relates to CARE maps, which is, if I just briefly explain what that is, it's a specific method that we've developed at CARE to select the best embryo for transfer. So it's completely non-invasive. It uses time-lapse imaging to take a photograph of the developing embryos every 5 minutes or so throughout the whole culture period. So we don't need to take them out of the incubator to assess them. And then we've developed algorithms, so looking at the transfer of 8,000 embryos, that we know whether they've resulted in a birth or not, and looking at the difference in behaviour, of developmental behaviour between those 2 groups of embryos. So we can select the best one with higher confidence and get a shorter time to pregnancy, get the best one first time, based primarily on the way it's developed, and not so much on how it appears, how it looks, the morphology. So one of the questions earlier was about fragmentation. So embryos do fragment, and sometimes if it's severe, it is bad news, but often it doesn't interfere too much. It's just something that human embryos do. Much more important is the way they develop and the time they divide. So CARE maps has been developed based on that theory over 10 years, and we're very confident in it, and we recommend it to most patients.
Yeah, the very good question came in just now while you were talking there, Ali, you probably didn't see. What about the over 40s? Would we still put 1 back? So that depends, as it always does. So if you knew that embryo had an excellent chance of implantation, then yes, you would only put 1 back. How would we know that it had an excellent chance? Well, we look at CARE maps, we look at all the other information that we can get. We may even have done a biopsy to show that that embryo is has normal chromosomes. In those circumstances, definitely 1. If we found that we weren't sure which one of 2 embryos had the best chance, and we thought that maybe neither of them had the best chance, then we might put 2 back. I agree, to maximise the chance. So particularly if we didn't believe that they would survive the freeze-thaw process, for example. If they're going to survive freezing and thawing, and in Ali's team's hands, that's about 99%. 99 a bit percent. So we're not harming the embryos by freezing and thawing them, and so you can make the case there for putting it back 1 at a time again. So yeah.
Do you think we need to talk, we've not got much time left, but a bit more about genetic testing? So this is pre-implantation genetic testing for aneuploidy, PGT-A. So what happens here, it's recommended mostly for women of advanced maternal age, so over 38 generally, but can be for other indications as well. So in the lab, we take just a few cells from the blastocyst stage embryo. So it's been growing in our incubators, hopefully in our time-lapse incubators, so we can see exactly what's going on. We take a few cells and send them off for a genetics lab to count the chromosomes, to count the copy number of chromosomes. And what we're looking for is the right balance of chromosomes, and we will preferentially transfer those embryos which are euploid. That's the normal copy number, and that gives the very best chance. So that's in a nutshell. There's much more information, of course, around that, but in your consultation, you would learn all about it.
And it only tends to be offered mainly for the older patient or those who've had recurrent problems, because they're more likely to have an abnormal result. So someone in their first cycle in their 20s is very likely to have a normal or in embryo, whereas that isn't the case as time goes on. So yeah, it's something to be discussed and thought about. But there's a lot of these additional treatments, and you know, I think we have to be very upfront and honest about the reasons that we recommend it and who we recommend it for. And not everything is right for everybody. So that it does form part of a discussion in the consultation between the team and yourselves.
Yeah, there's one quick question about is it expensive, PGTA? Well, we go through all the costs. We do a costed treatment plan with every patient and discuss the pros and cons of every treatment, very personalised consultation. Those sorts of treatments like PGTA that we talked about, care maps, there are added costs, but you have to balance the benefits of them. So the likelihood is, or the hope is, that it would minimise the chance of having to have repeat cycles, and so in fact become quite efficient way to have treatment. But everything needs to be personalised, and we would talk to you on an individual basis about that.
There's a little bit of debate going on about adding on treatments to NHS funded patients, and I think that's important just to cover that one off, is that in some areas the CCGs will allow you to add on various things that the NHS is not paying for on your behalf, and in other areas they say that you can't. Now, we would challenge that, and we are looking carefully at that as to whether that's actually something that the NHS is able to do. So it may be that we can challenge that on your behalf if you are particularly keen on something that we can offer that the NHS is not paying for.
Yeah. So I think we need to tie it up, really. Should we just go once more over the inquiry team phone number, because that's been asked just now, is 0800 564 2270 if you want to make an appointment. I think it was an egg donor who wanted the contact number. Also, all this information is available on our website, carefertility.com, and all the social media channels. You'll be able to watch this back and look at the previous one about starting fertility treatment with Dr Sefton and Dr Barry, and we mentioned also Charles Kingsland's wonderful sessions that are also available there. Anything else you want to add, Mark?
Just to say that, Ali, we've got the two coming up in the near future, and there's been quite a lot of questions on donor eggs and sperm and embryos and things, and we haven't covered that particularly well this evening, but there is one coming up in the near future for that, which should answer your questions. And I would just round off and then hand back to Ali, just to say that if you are thinking, should I go through treatment now or not? Should I have the vaccine or not? What should I do? Where am I? What's going on? I would say proceed. I don't think anything's going to change in the very near future, and I would encourage you, if the time is right for you, carry on.
Yeah. Oh, and it's nice to see all these little hearts coming up in the corner. I'm not very familiar with Instagram, but it's nice. Mix. You're not sending those to me, are you, Mark? No.
No, I'm not. No.
No, I know. But it's lovely to see.
There's a positive side. I could imagine a few others that might be coming up which we're not seeing, so that's good.
All right, it's lovely to see you, and thanks for joining us. And we'll be back very soon with more focus on donation and male factor.
Okay.
Thank you.
Yeah,
thanks.
bye-bye.
Bye. Bye.